Good morning, everyone. And my name is Louise Ivers. I'm an infectious diseases doctor at Mass General Hospital in Boston, and I'm the director of Massachusetts General Hospital's Center for Global Health. Welcome. Thank you for joining us this morning or this afternoon, depending on where you are. This panel is a technical panel that we aim to address the unique challenges for those who are working in lower resourced settings responding to COVID-19. We're trying to bring together experts from around the globe to discuss how they've been addressing the challenges. And today I'm really delighted that we're going to be talking about a very important topic, which is COVID-19 in pregnancy and childbirth. Our webinar is being recorded. It's going to be posted on the Global Health website, which we'll share with you at the end. And we also are going to be posting it to our YouTube channel. I'd like to introduce our panelists and then hand over to them to discuss. We're going to have Dr. Adeline Boatin speaking. She's an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School and at Mass General Hospital. We have Dr. Gadama, who is the head of obstetrics and gynecology in the College of Medicine in Blantyre, Malawi. We have Anna Grace Auma, who's a lecturer at Lira University in the Department of Midwifery in Uganda. And we have Miss Julie Mann, who is Associate Director of Midwifery both at Mount Auburn Hospital in Massachusetts and also with Seed Global Health. So I'll pass it over to Dr. Boatin to get us started. Thanks, Adeline.
Thank you so much, Louise, and thank you for giving us an hour to talk about COVID and pregnancy. It's something near and dear to my heart, so I'm glad that we're spending some time on it. You can go to the next slide, Carrie. So my goal in these quick 8 minutes is to give you a rapid review of the literature that we have to date of COVID-19 and pregnancy. I do have a few caveats that the literature is limited, and so there are a lot of questions that we still don't have answers to, or at least we don't have definitive answers to, and it's literally evolving day by day. There's publications coming out probably since I last checked yesterday, and so there may be things that I've missed. I also didn't do a systematic review, although I tried to do a pretty thorough literature review, so there probably are a few studies that I might be missing here. You can go to the next slide. So my data sources, one of a residency class from MGH and Brigham put together this website, which you can go to, that lists and updates publications that come out related to COVID-19 and pregnancy. So I borrowed a lot from that, also looked in PubMed. And then I want to give some thanks to Andrea Cirinello, who's an ID, perinatal ID doc, and Ilona Goldfarb, who's a maternal fetal medicine doc at MGH, who lent me some of their slides. And then Lynn Moffinson, who presented a webinar on COVID-19 and its impact on pregnancy. Go to the next slide. So this map here just shows where the studies that we have to date come from. Of 33 primary studies reporting data and 5 reviews, you can see that most of the studies are coming from China to date. There are a couple coming from Iran, one from Honduras, one from Peru. And so as we think about how this evidence might apply to lower resource settings, I just wanted to have you bear this in mind, that a lot of the data so far is from China, which is a middle income country and fairly resourced, as we saw by how rapidly they built some new hospitals. So the outcomes may not necessarily apply in other settings. Next slide. And also, as you see that the epicenter of the pandemic has shifted more to Europe and the Americas, even though currently a lot of the literature comes from China, I imagine that over the next couple of weeks to a month, we're going to have a lot more information coming from Europe and North America. Go to the next slide. So one of the questions that we always want to know to start off with is, are pregnant women more likely to get this virus? And this is one of the areas where we really have no good answers. There are no true population level surveillance studies that are able to answer that question. The best we can do so far right now are 2 studies, one out of Italy, one out of New York, that give us some sense of prevalence. So this study out of Italy was a maternal hospital hub for all the hospitals in the region. So they were getting all the cases that were reported for one region, and they reported 40 cases out of an expected 7,000 deliveries. And so these were really just for women who were at term coming in to deliver, and that ended up being a prevalence of about 0.6%. in that region. I think interestingly, one of the studies that came out quite recently from Colombia, where they started universally screening all women who came into their maternity ward and were admitted, regardless of whether they had symptoms. What they found was about 15.4% of those who were screened tested positive. And I think what was remarkable about this is that almost 90% of those were asymptomatic at the time of testing. And so that has actually really changed a lot of practice across centers in the US, where there is the capability to do universal screening. Now we are doing universal screening for people who are coming in for labor and delivery. And in some hospitals, that's becoming anybody who's coming in to be admitted. Go to the next slide. So the question is, do pregnant women present similarly to non-pregnant women? Next slide. There are very few studies that actually do this direct comparison. So this again is of those 33 primary studies that I looked at. The majority of them presented pregnant patients only with only COVID-19. So there really aren't studies that are comparing pregnant women to non-pregnant women, and then also among pregnant women comparing COVID-19, patients with COVID-19 to patients without COVID-19. So our data is quite limited to really answer those questions. Next slide. What has been done though is when you compare symptoms that are reported in the literature, it does appear that they do have similar symptoms. Maybe a little less cough and fatigue, but across the board, fever is still the most commonly reported, next followed by cough. And so quite similar in terms of pregnant versus non-pregnant in terms of symptoms. Next slide. The lab side findings are also quite similar, with lymphopenia and an elevated CRP being things that are remarkable. And again, a vast majority of pregnant women who have COVID-19 also have alterations on chest imaging. Next slide. Is the disease more severe in pregnant women? Next slide. So again, we don't have really great data for this. This is a study that also comes out of New York, where they reported the first 4 weeks of cases there. So they looked at a large hospital group in New York State between March 2nd and 29th and looked at the rate of admissions per week. And in this figure, you can see them comparing the rate of admissions for non-pregnant women in the blue hash compared to pregnant women in the burgundy color there. And so they sampled over close to 22,000 admissions across 14 hospitals. And that ended up having about 3,000 pregnant women. And the rate of admission was much less for pregnant women compared to non-pregnant women. And this is, the thought was that pregnant women are likely to be younger, less likely to have symptoms. And this is really people who are symptomatic and requiring admission. So it's not necessarily a prevalent study, but it does seem to suggest that there isn't any more severity in pregnancy, certainly, and it's a different population that's being admitted to the hospital. Next slide. Are pregnancy outcomes worse due to COVID-19? So this is just restricting our population now to women who are pregnant. Again, we don't have a lot of studies that have direct comparisons, and so a lot of our data right now comes from case reports and case series. There are a few systematic reviews that have put that information together. What comes out of those systematic reviews, and I think this is, again, because a lot of that data is coming from China, is that the vast majority of these women are having cesarean delivery. So that is true across the 4 systematic reviews I listed. None of the systematic reviews have found any studies that mention any maternal deaths as a consequence of COVID-19, although there was at least one case report from Iran that I saw that did mention a maternal death. And then there was an unpublished report of a second maternal death as a consequence of COVID-19 in Iran. A couple of studies have found one stillbirth and neonatal death, and I'll talk a little bit more about vertical transmission. You can skip to the next slide. I think it is interesting to look at the indication for cesarean delivery. I think it gives us a little bit of information about why that might be the case and how that might be different. As a whole, China has a fairly high cesarean delivery rate, so it's perhaps not surprising that the skew towards cesarean delivery is around 96% from these reviews. And as you can see from the indications, they're the vast majority are COVID-19. And even as you look at the other list, there are some that are, it's questionable whether they were because of COVID-19 in the setting of other obstetric complications or obstetric complications in of themselves. This systematic review did find us what seems like a high rate of preterm birth, so about 39% of those women who were delivered. But again, we don't really have comparisons to see if this is different. Go to the next slide. And the next slide. Keep going, one more. Skip through this. I think this study is the one study that does attempt to try to compare pregnancy outcomes in COVID positive versus COVID negative. What they did is they looked at their confirmed cases and suspected cases of women who were symptomatic or had chest CT findings, but weren't SARS-CoV-2 positive on PCR. They compared those to a control group that was randomly selected of women admitted around the same time in 2020, and then also to a control group that was randomly selected from 2019. Go to the next slide. And what you find is that the C-section rate is much higher again in people with COVID-19, and with that likely being an indicator for why people are having C-sections. Next slide. Complications also appear to be higher. They didn't quite list what those complications are, so it's hard to delve into that. Next slide. And then there were some trends towards increased prematurity, low birth weight, and some differences in birth weight mean, although those are likely not clinically significant differences. Next slide. Is there any evidence of vertical transmission? So there are a lot of studies, case reports, that point away from evidence of vertical transmission. These are the studies with fairly small numbers that you can see. Not all of them have robust testing, and the timing of that testing is a little bit different. But these all have been negative studies where they have isolated babies and not found any case of vertical transmission. Next slide. There are, however, a few studies that raise questions of vertical transmission. Again, small numbers, and still nothing definitive. So in one study, they found that in 2 of 6 neonates, there was IgM found antibodies in the neonate, and usually IgM does not cross the placenta, so that finding raises the question of the neonatal infection. And then there were 2 studies that reported positive nasopharyngeal swabs for the neonate soon after delivery. So the one was day 2 and 4, and one was at 16 hours, again with reported isolation, but those did not, one did not check for IgG and IgM, and in the other one, those were negative. And then in one other study, they found that the PCR was negative, but they did find both IgG and IgM to be positive. So to summarize that, one systematic review looked at 12 studies and had 68 deliveries with 71 neonates and found 4 cases of infection within 48 hours of life. So not a whole lot of data pointing towards that that's conclusive, but certainly still a question that remains to be answered. Next slide. Any evidence for in utero effects? Next slide. And the answer to that simply is we really don't know. This again shows the 33 primary studies we have, and the vast majority of those are in the 3rd trimester. So data from women in the 1st trimester or the 2nd trimester who have then gone on to deliver, we simply don't have that yet because of the short time of this. The indirect effects are also important to think about. Next slide. These are just some graphs showing changes in facility-based deliveries and antenatal care seeking in Sierra Leone and Guinea through the Ebola virus pandemic, where you saw the institutional deliveries go down, antenatal care go down, and maternal mortality go up. And there hasn't been anything published in the literature about COVID-19. Next slide. But there are some media reports that hint at that, and so something that we definitely need to keep our awareness of. Next slide. Stay tuned, because there are a lot of work trying to gather more information. There are a number of registries, you can go to the next slide, that are in the US and across the world, where we are trying to understand better the impact of COVID-19 in pregnancy. So I think I will end there.
Wow, thank you so much, Dr. Boatin. That was an amazing review of the literature. And for those who are in the audience, we are recording the session and we will post it. So if you want to refer back to some of those studies and listen through that, again, you'll be able to do that. And I'll invite you in the audience to submit any questions you have for our panelists through the Q&A feature. And while you're doing that, I'm going to check if we have Dr. Gadama with us. Yes, hello, welcome. Dr. Gadama, please go ahead, the floor is yours.
All right, no, thank you for joining in. Really, I will just give an experience from the sub-Saharan setting. This will be in Malawi, and I'll just touch a bit of what literature has. So the outline really will cover the impact of COVID in pregnancy, our experience in the labor and delivery, the breastfeeding side, and the challenges that we're facing this side. So Adeline has already spoken about the impact of COVID in pregnancy through the literature and the studies that have been done. But really, in general, we know that in pregnancy, there are significant physiological and immunological changes. There's been other viral pandemics that have come in. We had the SARS that came through and the impact it had on the pregnancy. And currently, really, we're still waiting for information either to try to signify or quantify this problem in the pregnant mothers. But the emphasis that we're giving on pregnant mothers is that they need to protect themselves from infections, really because of the consequences that these illnesses have in each and every trimester that comes through. Next slide, please, Kerry. So the message is that we're sending them really sensitization talks, the emphasis from CDC, this should not be overemphasized, and we're trying as much as possible to train the community, the health workers, as well as our pregnant mothers, and the importance of all the steps that are needed to protect themselves. And these talks still going on in the media through also in antenatal classes. Thanks, next slide, please. I think really the challenge we have in our setting, we are trying as much as possible to offer screening and triaging of these cases, and then before they enter into labor or delivery units. Now, the suspected or the confirmed cases, we are trying as much as possible to see if we can offer them a respectful and dignified care. You understand that in most of our settings, bringing this respectful and dignified care in isolation units becomes a bit of a challenge. Currently, cesarean section is only done as per obstetric indication. So although we haven't had any cases yet for our center, but really this is the protocol that we have come in. We know definitely that there's little information on the perinatal transfer that has been documented, little numbers on sample size, but these are the things that we should be encouraging. All the health workers that are looking after either suspected or confirmed cases, proper donning and doffing of these PPEs is something that can't be overemphasized. And we currently evidence really hasn't supported any viruses being isolated in amniotic fluid. Thanks, Kerry. Right. Spread of COVID-19 is via respiratory droplets. And if comparing breastfeeding and formula feeding, we can't overemphasize that breastfeeding is superior. Really limited studies have shown that COVID-19 has not been detected in breast milk. But what we're trying as much as possible to promote is that there should be breastfeeding being promoted, be it direct or via express breast milk. And the hygiene measures, moms should wear face masks, hand hygiene things should be done, skin to skin, kangaroo mother care should not be overemphasized. What we're looking at in this casing that actually for breastfeeding it's far superior for bonding and other issues that comes with it. One of the things that we should trying as much as possible to teach the health workers as well as the moms and the guardians is that actually the newborn is acceptable to person spread. So all the measures that are being done on mothers, really they should also be taken on the little ones, and also routinely cleaning and disinfecting surfaces is something that we're trying to support as well. Thanks, Kerry. Right, so challenges we're having mostly in our setting is the limited screening and testing kits. We are only testing those that are suspected, but really it's the testing kits have to be shared with the other population. The other thing, I guess it's worldwide, but we've been hardly hit in the sub-Saharan Africa or in the low resource settings, availability of PPEs. There is a move to try as much as possible to be promoting reusable gowns that can be sterilized, because currently we can't even get supplies. Most of the supplies were being imported, and with the lockdowns across, this is one of the challenges we're having. Isolation units, if you look at most of the isolation units, they're not pregnancy friendly. If you look at those isolation units, really, you have to look at the issues of human resource. You have to ask, we've got few midwives, few clinicians looking in the labor and delivery settings, and isolating, having an isolation unit, getting some of these human resource to those isolation units, you're also creating another shortage on the other side. The labor and delivery place is about migrating. So we're trying as much as possible to promote an isolation unit that can cater for a labor and delivery. Also an isolation unit that can also cater for an emergency cesarean section if it's indicated. We're also looking at an isolation unit that can also cater for the neonates. So our colleagues in the pediatric side, they have to come in that place. But as you know, obstetrics is very variable. There are also other coexisting maternal morbidities like severe preeclampsia that can come in with the superimpose these cases. So these are the things that, how do we move in this pandemic when there are comorbidities, and how can we make a friendly, dignified care we can provide to our pregnant moms in the isolation units? And also, how can we have available resources, PPEs, human resource, and testing kits? And these are some of the things that we are faced with in our settings. But good to say that so far we haven't had any confirmed cases, but we have got suspected cases that were negative, but there's still scenario of having a setup of isolation unit that can cater for these. And also, in most of the time, most of the sick mothers are sent to tertiary centers, but as you are aware, anyone can be affected. So we're trying as much as possible to trickle down using district hospitals as well to be having isolation centers that can look after the pregnant moms. That's what I had in short about the experiences we have and some of the things that we envision that we'll get through as we go along. Thank you.
Well, thank you so much. I really appreciated that. Let's stay with us, and we're going to come back to questions for all the panelists after. A lot of great information, and also some challenges that you're mentioning, especially around testing and availability of PPE. Let's turn to Ms. Anna Grace. Over to you.
Thank you, Louise. Thank you so much for the opportunity. I am Anna Grace Auma. I'm in Uganda, Lira University. COVID-19 response, I would like to share in what is going on in Uganda currently. We have so far tested about 16,000 cases cumulatively, and about 74 confirmed cases, with 46 have recovered and have been discharged home. Still 18 more active cases, and so far no death, and one case of COVID-19 in pregnancy. This was a one-time case, and this has still left us with a lot of gaps to think through. Next slide. This young woman was a 22-year-old who was confirmed COVID-19 and was admitted at Entebbe Isolation Unit. She gave birth to a baby girl by cesarean section on 22nd. And both mother and baby are said to be in good condition, with of course a lot of questions still to be answered. So far in the country, we seem to have a lot of gray area on COVID-19, looking at the number and a number of other challenges that are yet to come. The health workers have been on the front line, but so far we have not had any case of a health worker that has contracted the infection. This particular delivery took place in Entebbe Hospital, which is a fairly equipped hospital in the country. We can't compare it with any other facility up country. And this leaves us with the question of how about other facilities? Can they handle a pregnant mother? That question is hard to answer right now. So far, the task force within the country, national task force, and districts, every district has a task force to try and respond to COVID-19, with about 17 isolation and treatment centers all over the country. One operational testing center currently in Entebbe, and the other 3 are yet to be set across the different regions of the country. And there is active screening at every health facility, but this is just screening for signs and symptoms. But the question is, for those who don't have symptoms really, and yet they may be carrying the infection, what happens? It means we're likely to have the infection being carried around. That therefore says that we still don't have the capacity to test everyone in the country or test any person who comes to the health facility unless you have signs and symptoms. Thank you. Next slide. So far the country has come up with a number of do's and don'ts to make sure we stay safe and stay at home. And these 33 have really been put into active implementation. There's also massive community resource mobilization to try and respond to the infection, to the pandemic. And then active case finding. This includes contact tracing. For those who have been confirmed positive, we try to trace contacts and put them in isolation centers. Trainings have been done throughout the whole country on COVID-19. But one other neglected area of the training has been COVID-19 in pregnancy. Thank you. Next slide. Are the gaps. So far, PPEs may be the other very important aspect of healthcare delivery or healthcare provision, and yet the country currently faces a lot of challenges, as Uganda has been relying on a lot of imports from other countries. And so we are unable to have the adequate PPEs that we needed, and that's why we're actively mobilizing resources from within to try and have the PPEs within the health facility. Lack of training, especially for midwives, how to handle COVID-19 in pregnant women. And this so far has been done in about 3 centers in the country. We hope to trickle down the training to the up countries and to every facility within the country. There's no specific isolation place for pregnant women, and therefore this leaves a no treatment center designated for just pregnant women. Even within the treatment centers, we may have a delivery unit that is, yes, because it's already a treatment center for COVID-19 only, but what about other facilities that are not treatment centers that attend to these women? And then resources really are coming down, but we hope they reach everyone within the country as soon as possible. Otherwise, we may have a lot of unanswered challenges. The other thing is that right now we're on curfew, and that limits public transport to wherever you have to go. It has greatly reduced the number of pregnant women attending routine antenatal care, attending to other minor ailments in pregnancy, and attending to any other treatments, like if a pregnant woman is HIV positive, she needs to get in her drugs and all that. This has reduced this, and we are likely to face a challenge with time, because then you get into what you've not prepared for. Also, other neglected conditions in pregnancy that women seem to discover them when they come to a midwife may as well be neglected during this period. And yeah, those are some of the things we are looking at right now. Thank you. Next slide. These are just some of the midwives, nurses and midwives on the front line in one of the hospitals. Thank you.
Thank you so much, actually. And of course, 2020 is the International Year of the Nurse and the Midwife, and your frontline in so many aspects of healthcare and healthcare delivery, and for sure now in this pandemic, you've even shared that experience. May I ask you, because we already had a question from the audience about whether you are actually seeing reduction in visits related to antenatal care and delivery in your place in Uganda or Malawi, because women may fear they could get the virus, or they're afraid. Are you already seeing that, or is that just something that you're anticipating might happen? Anna Grace, maybe you can answer that first, and we can turn to Dr. Gadama as well.
Thank you, Luis. In fact, in the first weeks when the first case was announced in Uganda, confirmed, we had very few cases in that first week of antenatal visits and immunization units. Even in other outpatient attendances, the cases reduced. And this was, I think, a very, it raised a concern. And I think most of it was because everyone was scared. The hospital seems to be the other place that you're likely to get the infection if you don't mix with other people in the community. That's what the community presumes. And yes, we have a reduced number of pregnant women coming to routine antenatal care, and a reduction in women seeking care due to minor ailments. Thank you.
Dr. Gadama, in Malawi, in your center, are you seeing a reduction?
Yeah, actually, we are, with us, the antenatal clinics, there's a reduction in the numbers. But when there's any ailment or labor and delivery, there hasn't been any change, because most of them actually have been advised to seek a facility-based delivery. So we haven't noted any change on that side.
Okay, that's good to hear, but we'll be, I'm sure, keeping a close eye on that. Let me pass to Julie Mann for our last set of formal comments, and then please, I see from scanning the audience a lot of expertise in our attendees, so please do go ahead and submit comments or questions through the Q&A feature, and we'll come back to those to discuss with the panelists. Julie.
Not sure who put that last slide up there, but I like it, but that wasn't me. Thank you. But so I'm Julie Mann. I am a midwife on the front lines, have been working with COVID positive and COVID negative pregnant women at my facility. And I'm going to share with you, thinking about inpatient obstetrical care of both COVID negative and positive in triage, interpartum, and postpartum. As Dr. Gadama and Anna Grace mentioned, it seems like facilities are trying to target one place to send women who are screened positive or known to be positive for COVID. But, you know, in obstetrics, we don't have the luxury of, you know, time sometimes. And so I think I would urge everyone listening to think about their own facility and how you might handle a woman who screens positive or is known to be positive for COVID, because you know, she might be in labor and you have to treat her. And so, next slide, please. Yeah. So, in developing protocols for our hospital and looking at all the WHO, CDC, and all the resources and the data that Adeline presented, you know, I think everyone should think about their patient flows and their workflows in assessing every pregnant woman that comes through the door. And so this is a framework to think about your own settings and what, how you might address each and every pregnant woman. And I think the most critical piece here is the triage piece. It's almost a two-tiered triage that we need to do of all the women seeking care. Is first, screen them for COVID and separate those who screen positive and screen negative, and then screen them as you normally would for their obstetrical indications. and then go on to the interpartum and postpartum periods. So I'm going to walk through this framework very briefly and hopefully give you some ideas about how you might prepare your site. Next slide. So, ideally we would love if all patients were announced, if there was some sort of alert system that you could set up via telephone, WhatsApp, text, an ambulance coming in, carrying a patient, so forth. And then you could screen them for COVID over the phone, and you could prepare. You could prepare your staff, your room. I know it's a challenge to find an isolated room, but it could be an isolated area with a curtain. You could prepare your PPE cart, and then you could have it when they arrive. You could have a designated area, whether they stay in their car, in the ambulance, or a designated space where a staff member could come in the PPE available and escort them to that designated room that limits exposure of that patient to every other place in the hospital or the clinic. And then ideally having the patient and support person masked, whether they bring in their own mask or you're able to supply them. But in reality, that's often not the case. Most of our women are coming in unannounced. They don't know when labor is going to be starting, and so they arrive. And so I think we have to think of a system of these unannounced patients. And so the first and foremost, you have to think about your signage at your hospital or clinic. Where should these women be going, and have to make it clear that they know where to go and to be screened. And then think about your screening area. Is that at the entrance of the hospital? Is that at the entrance of the labor ward? Is there a tent or a table outside? Who's doing the screening? And that screener should always ideally try and be masked. And then your volume. If you have low volume, maybe you could do it on a one-on-one basis. Someone arrives and you go out and greet them and you screen them, and then you decide where they should go. Most of the sites probably have higher volume. And so thinking about your screening area, should you have two separate lines of, and the women self-select, and which line do they have respiratory symptoms? Do they have fever, or do they not? And then, having that area equipped with maybe a plastic screen for the screener to sit behind. And then again, thinking about masks for patients, maybe encouraging them to make their own masks, because PPE is clearly an issue. Next slide. And then there's the issue of the COVID screening. So the screening tool that your location has decided to use, WHO and CDC have a little bit different symptoms that they screen for. But they all include fever, shortness of breath, cough, GI symptoms. The issue here is that some of these symptoms are inherent in pregnancy. Women can have chorioamnionitis and have fever. They have diarrhea in labor. They have rapid breathing. They could have fevers of other origins. So, it's not clear-cut screening these women in pregnancy. And so, we have at my hospital, and I think, something to consider is to err maybe on the side of caution. And if, you're unable to determine, is this pregnancy related or is this COVID related, screening them positive, and then going from there and testing if available. And certainly at these screening stations, taking temperatures. A lot of our patients don't say they feel feverish, but they don't have thermometers at home. So definitely making sure you have the thermometers to screen and take their temperatures at these sites. And then you separate them out. And so you have the screen negative. And I'm not going to say much about this, but there are some considerations here. You treat them normally obstetrically, you can. There are, as Adeline noted, there's a lot of asymptomatic carriers that we are finding. And so should every woman and support person be masked? And should all healthcare workers, even if they're taking care of screen negative patients, be masked? There is some talk, and a lot of places in the US I know are doing this, for second stage of labor and pushing, using PPE and N95s. Second stage in and of itself is not an aerosolizing generating procedure, but it has a potential in emergencies to quickly become one. And you are in really close contact with these women during second stage. And again, there's the issue of asymptomatic carriers. And then just thinking about overall general discharge teaching of these mothers. So that's a screen negative, but more importantly, the screen positive. so you've screened them, they screen positive. Ideally, you would want to evaluate them immediately in an isolated area of some sort. If your volume is high, you can't screen every woman immediately. So thinking about where is your separate waiting area going to be for these women, and that the separate waiting area, thinking about separate amenities for this area, and benches and seating at least 2 meters apart or 6 feet apart. Thinking about a dedicated staff member in PPE in that area, and then again, masking. And then, so you screen them for COVID, they're in this designated area. Now you have to do what you normally do. You screen them obstetrically. And as all the panelists have said, you screen obstetrically based on clinical indications. Your treatment of these women should not be based solely on COVID. It should be made on clinical indications obstetrically, with the caveat of assessing women for severity of illness in COVID. And this is an illness severity assessment that ACOG has come out with that we use. That's very helpful, and that can help you sort of elevate the level of care if they are having respiratory symptoms and need further team support. And then other things to think about is in these areas where you're treating COVID positive or screen positive patients, minimal supplies in the rooms that you're screening them, because anything in that room could have, the surfaces could become infected. And so, thinking about a supply cart outside the room. And then because you're caring for the patient, you want to limit your access in and out of the room. Thinking about having a runner outside that room to get supplies for you, to get meds, so that you do not have to continually go in and out and maybe contaminate. And then, of course, COVID testing as needed and as available. And so you screened obstetrically, they're in labor. Now, if your protocols, dictate and you have the luxury of time, transferring them to your designated sites, but sometimes we don't have that. So, managing these women, again, based on maternal and fetal indications, isolated area. We do the severity of illness for COVID screening, Q4 hours. Thinking about pain management, a lot of sites don't have access to epidurals, but it is something that we have begun to encourage. These women are alone often, they don't have a lot of support. Nitrous oxide and oxygen for intrauterine resuscitation people are not doing that these days. Some discussion around, is that aerosolizing or not? Skin to skin, I think Dr. Gadama noted this a little bit. WHO says fine, CDC is non-committal, and the American Academy of Pediatrics says at maternal request because of the risk of transmission. And then delayed cord clamping, again, unclear evidence. It doesn't look like there's vertical transmission, but should one be doing delayed cord clamping or not still in this time of COVID? Again, thinking about your equipment, disinfecting it, limiting staff, in and out, bundling your tasks that you do when you're in the room with the patient. And then again, rooms minimally stocked, and thinking about a runner who can get you what you need so you're not going in and out of the room. And then the woman delivers postpartum, again, doing daily severity illness assessments. NSAIDs not contraindicated in pregnancy on postpartum pain, and then considering early discharge, but in discharging these women and their babies, thinking about their resources and questioning their ability, their food security. Can they self-isolate? Can they, what is their hand washing situation? And then this family planning is big, especially as we've been talking about with decreased visits, antenatal visits, postpartum visits, thinking about immediate family planning, so placement of immediate IUD or LARCs or OCPs upon discharge from the postpartum unit. Then just to comment on support people, this is a big hot topic, for a facility to decide at your own local level. We have instituted one visitor per person, but if you do decide a visitor, it should be limited. They should be screen negative, hopefully masked, and should definitely not leave the facility and stay with that person the entire time. And then we've talked a lot about babies. I think most of this has been covered. Breastfeeding, and the baby should be suspected as possibly COVID positive. You need to think about your facility and as a separate COVID nursery if that baby needs special care. And then what we've been doing is, cohorting the mom or in-rooming the baby with the mom, but in an isolette. We have lots of isolates that are just sort of sitting around. So the baby's with the mom, but maybe decreasing some of the exposure, leaving the vents open and the hand holes open in the isolette. We're thinking about a crib with a curtain between the mom and the baby. I think that's about it. These are some resources. Thank you.
Thank you, Julie. So let me ask you a question, Julie, and then I'll turn to some of the other questions. So in your facility in the US, in Mount Auburn, are all the healthcare workers wearing masks, or what's your standard kind of protection within the hospital right now?
Yeah, it's evolved. In the beginning, no, we didn't know if we had enough masks. And then we had enough just surgical masks, so everyone was wearing surgical masks. And then if we had a COVID positive or screen positive patient, then we would put on the full PPE and 95 goggles and everything. And now we are doing, for every second stage of labor, we're doing full PPE.
Okay, thanks. First, I'm just going to bring a few of the comments from the audience. I noticed actually, Anna Grace, in your slides, when talking about social distancing, there was a photograph of police with a whip running after the ladies at the market. And from a public health perspective, obviously, we know that social distancing is an important way to slow down transmission. But we've heard that the social distancing rules and regulations may be kind of impeding pregnant women and other sick people from even being able to make it to the hospital. I don't think, I think we all on the phone and on the panelists need to continue to be advocates and allies for women, and thinking about how we can ensure that while social distancing is put in place, that the lockdowns are obviously very complicated. They're complicated economically, and we have to figure out ways that women can get passes to be able to go when they're pregnant. But we have a lot of technical questions as well, so let me turn to some of those. Is there any reason to think that cesarean section early or cesarean section for women who have COVID is an important step in the process, or is that an indication for cesarean section? Maybe I'll ask Dr. Boatin that question.
Can you hear me?
Yeah.
So I think that is likely needs to be in a case-by-case basis. I think in of itself, having the disease alone certainly does not merit a C-section, especially with no evidence to suggest vertical transmission from a vaginal delivery. There's no reason to do a C-section to prevent vertical transmission that we know of right now. For women who are sicker, sometimes it's sort of weighing the balance of the risk of the C-section and the gestational age as to whether that is going to help. But there have been some cases at our institution where women have been quite sick, and so delivering her early and delivering by C-section to remove the load to allow increased lung compliance has been done. But I don't think it's something that we do as a general policy. It's more case by case.
Okay, thanks. Dr. Gadama, I'm going to put this question to you. So in all of the triage conversations, and Julie showed this very pragmatic approach to screening women, symptomatic or not symptomatic, but for this disease, for this illness, we have so many asymptomatic patients, or they're not really patients if they're asymptomatic. We have asymptomatic infected people who we believe are able to transmit. It seems that having access to testing is such a fundamental part of managing the epidemic locally as well as globally. Do you have access to testing at your facility in Malawi? Do you see a way for us to manage this unless we can get tests much more accessible?
Yeah, Louise, I think for us, really, the main limitation are the test kits. We've had labs that have been instituted in each and every central hospital. Now the challenge is, if we do mass testing to everyone asymptomatic, do we have the capacity? So if there is capacity, then I guess it's something really with the upcoming evidence in the literature, it's something that we can still motivate for, to say, for our case, yes, we can support that.
We're joined also by Dr. Vanessa Carey, who's a critical care doctor at Mass General Hospital and also the CEO of Seed Global Health. Dr. Carey, I just want to pass to you for comments. Maybe we've talked before about access to PPE and approaches to PPE in settings where in the global marketplace, it's so hard for many countries to even purchase the PPE. Can you make a comment about this as it relates to the topic today?
I mean, I'm not sure I'm going to add anything beyond what has already been said. I want to thank actually our panelists, because it was a really extraordinary arc of discussion from what we know, what we don't know, what the practices are in these different settings, and what might be kind of proposed best practices for this. And I think the thing that has been the most striking for me has just been the fact that the real challenge in COVID, obviously, is how do we continue to provide basic and critical services in the face of a pandemic? And obviously, pregnant women and neonates are vulnerable throughout their entire pregnancy. And when we look at the fact that we're trying to achieve a goal of higher, getting people to get their prenatal care, in addition to what that moment is in labor and delivery, there's many, many challenges in COVID. Certainly, PPE is going to be a front and center. Testing and PPE are going to be the two front and centers in terms of protecting the health workforce, but also protecting mothers. And so I think that as we, and there's going to be big questions about where you prioritize very limited PPE. I guess I would say that in the absence for healthcare workers, we obviously need them to have the most optimal protective PPE as humanly possible, because they're going to be going through stages of labor and delivery. There's processes of potentially aerosolization, whether in a vaginal delivery or in a C-section, and there's going to be bodily fluids and things that we know would put people at risk. And so face shields, masks are going to be critically important, gown, gloves. And I think that building a system for mothers also in masks, I mean, we now know that universal masks does seem to really reduce the transmission of droplets, and so the degree that we can at least augment PPE through cloth masks or any kind of mechanism of barrier, I think is going to be very, very important. Something is better than nothing, right? Ideally, though, we would be prioritizing PPE. And I think the ability to get, if you can't do a face shield, at the very least, if you can do glasses, goggles, something that might mitigate, anything getting into the mucous membranes of the eye at the very least. And if you can cover the mouth and nose, that would help immensely. There is some data, and do not quote me on this because I need to look into it much more, but there is some now new reports that we should all do our investigations into about whether sewing nylon stockings into cloth masks may actually augment the filtering capability of homemade PPE. And so I think that sort of trying to learn ways that we can augment PPE in the absence of being able to get what we know is the safest and most protective PPE, I think it's always worth trying to figure out again, because there are going to be facilities in more rural locations or that are less likely to be tapped into the national systems. And that, by the way, may be in our country as well. So all countries are subject to this, where I think knowing how we can find the most protective means in the absence of being able to find the sort of protocolized channels is going to be important if we're going to protect as many people all at once, including the mothers who are delivering or family members who might be accompanying them. So we need to be considering all of these components. There were a lot of really extraordinary questions though, Louise, so I want to make sure that we leave time to go back to them.
So thanks for that. We won't quote you, but we are recording you and we're going to post it on our website.
It's fine. It's just saying let's do our due diligence. But the point
I think for what, if we had, one thing I want to kind of highlight, because, interesting in the US, 7 weeks ago, we had 64 cases in our entire country. And yesterday in the state of Massachusetts, 3,500 new cases were diagnosed. And so what we're seeing is so many of our colleagues in countries in Uganda are doing a phenomenal job with contact tracing, and really caseloads are still low. But I think all of us who are in the midst of the epidemic are anticipating that you will have a lot more cases, as I think you all are too, and being prepared early. We were later moving to all healthcare workers wearing a surgical mask, but I could certainly envision early adoption of all healthcare workers in facilities in Lira or in Malawi, like early wearing face coverings and goggles, as Julie was suggesting, or Vanessa was suggesting.
Didn't the Brigham also just come out with studies saying they cut their cases in half among healthcare workers by adopting the universal mask policy?
Yeah, I saw that in the news yesterday, that one of the hospitals in Boston had said they really reduced their healthcare worker cases by wearing masks. I do think that testing is, some of the questions are about testing. Wouldn't it be better to test everyone? Should we test early? I think the answer is yes. Again, we're moving a few weeks ago, we did not have good access to testing in Boston, but we have the privilege of the resources to be able to make that happen. And pretty soon, every patient who comes to the hospital where we work will get a screening test, symptoms or no symptoms. So I think continuing to advocate for access to testing is really important, but also making pragmatic plans for where testing is still not available are really important. Let me take another couple of very technical questions, I'd say, from Dr. Milian, who I know is an obstetrician in Haiti. Any recommendation for steroids for fetal maturation, he's asking. Why is it okay to use NSAIDs? Thought that those were not good for COVID. Maybe Adeline, I'll ask you those questions.
Muted. Okay. So I might throw back the NSAID question to you as an ID doctor, but I will say that for the fetal steroids, we are still using them as needed for obstetric indications. I guess there's some question about whether steroids influences the course of disease for people who have more severe disease in COVID-19. And since nothing has been conclusive at this point, we are still just going by obstetric indication and not changing that practice. And for NSAIDs, similarly, we are still using them in our postpartum women. We have not stopped using those, but Louise, maybe you can offer, or Vanessa, for what's happening in the ICU.
Yeah, I think initially there were some concerns. In France, there was some comment about NSAIDs, but I have not found that to be holding true. So I think for those where it's indicated, to date, I haven't found any literature to suggest otherwise. Anyone on the panel have any other information on that? Things are obviously changing every day. So I always feel like every statement needs to be qualified by let's just check to make sure of that. But I think that's
the Director General of the WHO did just issue a statement to say that there has been no meaningful evidence to indicate worse outcomes with NSAIDs, and that people who really have have an indication to take them should just do it in discussion with the provider. Yeah. I think that's everyone kind of hedging their bets to the point, but there has been to Louise's point, or Dr. Iver's point, there's been no conclusive evidence to indicate worse outcomes. And that was really, I think, the concern for the NSAIDs, as noted, was because of the concern for how it might affect the ACE receptor, which we know is how the virus gets into cells. But there's nothing conclusive at this point, and the recommendations have been that if there's an indication for NSAID that is preferred, it's okay to take them.
Great, thanks. And so I'm going to put the last question to Julie, because I know that you've been actually delivering babies and moms with COVID. So we know that with people who have COVID-19, they often are having low oxygen saturation. And someone is asking, this seems to be pretty common. even though the person may not feel really short of breath. Are you seeing any fetal distress in those circumstances? Could you share a little bit, Julie, about what it's been like in those situations?
Sure. I have not seen, maybe Adeline has more than I have, but I have not seen significant lower oxygenation in our women. They've fortunately been pretty healthy. The main thing I've seen is just preterm labor, women going into labor, at 35, 36 weeks. And so, yeah, I haven't seen much respiratory depression and then fetal compromise because of COVID.
Great, thank you. I want to thank you all so much for joining us. This is really an all-star panel. I really appreciate you dialing in from Malawi and Uganda as well as Boston. I think we need to come back to this topic in a few more weeks when we have more data and more information and more experience to share. Thanks everyone who joined us on the line. We really appreciate it. So take care out there.
Thank you, everybody.
Bye.
Thank you.